Welcome to Mic'd Up with ChiroUp podcast, where I'm your host, Brandon Steele.
And I'm your co-host, Tim Bertelsmann.
And you're tuning into the one and only evidence-based podcast made by chiropractors and for chiropractors.
Here's how it works. We'll have a new clinical topic that we dive into each month, and you'll leave with practical skills that you can apply right away.
Well, that's contingent on who's giving the advice, and you'll want to take mine.
Let's dive in.
Welcome to the next episode of Mic'd Up with ChiroUp. This is your host, Brandon. And today's podcast is going to go through a couple different things, all pertinent to the modern chiropractor. First, the biggest challenge in practice right now that we're getting in our practice, and from what I'm hearing, it is not a unique challenge to my practice, Premier Rehab. The next is going through a condition, Meralgia Paresthetica. No, this isn't just for our pregnant patients. In fact, it's just the opposite. And then we're also going to go through a new strategy for our patients that get dizzy when they're getting on and off our table. This is going to be our patients with BPPV, benign positional paroxysmal vertigo. This is one of those conditions that we just keep on throwing Epley at, and that will help a lot of those patients with especially that posterior canal issue. However, there is a new spin on the Epley maneuver that I want to bring your attention to help more of your patients get out of these symptoms quickly. And then finally, I'm going to give you a couple of opinions. And the opinions are going to be mostly on podcasts, the ones that I really like, the ones I'm excited about, the ones I'm excited for that are coming out to hit the profession. Before we dive into that, if you get a chance, make sure to visit ChiroUp.com. Check out the resources tab. You can see the new blogs that are hitting, the new podcasts, the new webinars. Most importantly, where Tim and I are out speaking on most weekends, and hopefully meet up in person. Also, if you like the podcast, make sure to hit the like button. We always appreciate that. First, let's talk about Premier Rehab. For those of you who don't know, Premier Rehab is Tim and I's practice in Swansea, Illinois, just across the river over on the Illinois side, but we're essentially a suburb of St. Louis. And one of the biggest issues that we're having right now is hiring, finding someone. It's not easy. Now, in the past, we've had really good success with putting a note up in the office, put in a couple spots, let our patients see it, find someone who likes the practice, someone who's a past patient. That's worked well in the past. We've had a little bit of difficulty recently. We've also used Indeed in the past, both a great service. However, what I've noticed, not so much in the hiring process, but I want to bring to light something that has saved us and that has helped when we've gone through a transition in an employee, and that being Dashlane. That's right, the password manager. Think about this. If your key employee left tomorrow, would you know how to get into all the insurance websites, how to get into the time clock for your patients, the EHR, the bank, all those different things have kind of rely on one person or two people in your practice. Make sure you keep all your passwords locked in one spot. I know this has significantly helped us in a time of transition. The next is recognizing those employees that are stepping up. That when you're missing someone, we've got to get a little bit more out of those employees that are sticking around. We can reward those with lunches and also increase pay if they are doing increased jobs or increased skills that they have to learn with a missing employee. So two of the things that I think are very important. Historically, the patient is always right, or the employees or the customer is always right. I really think in this time we really need to take a look at our employees and treat them fairly and make sure they're compensated appropriately with their skills. All right, random facts of the day. Now this is, I'm going to give you one personal, I shouldn't say fact, we'll say one personal opinion of the day. And then I'm also going to give you a second fact, which is more research-based. And this personal one is a favorite quote of mine, and that is, comparison is the thief of joy. And the reason I bring that up is that working with kids, working with patients, working with employees, I always tell them, listen, you need to do what you need to do when you need to do it so you can enjoy the things you want to do when you want to do it. And that's never been more important to do, especially in our personal lives. Kind of forget about what everyone else is doing, the vacation they're taking, the car they drive, what they have, the clothes they wear, the way their office looks. Just do the things you need to do when you need to do it so you can enjoy the life you want to live. Second fact, I looked over our past blogs and the past podcast, and I've noticed a big trend and a lot of topics involving the glutes, the butt muscles, essentially, ischiofemoral impingement, deep gluteal syndrome, gluteal tendinopathy. And we see this so often, but one thing that I saw just come out in the research are two things to help identify, do we have the most common cause of glute pain, which is gluteal tendinopathy, as compared to something else. And those two things are this: if a patient with lateral hip pain stands on just that affected leg and it reproduces their pain, chances are you have gluteal tendinopathy. The next piece is my two-finger test, which is if you push on it, it hurts. But what is said is that patients with lateral hip pain who do not have any kind of palpable tenderness over that lateral side of their hip or the greater trochanter are unlikely to have MRI-detected gluteal tendinopathy. So what it tells me is that if you go to use the muscle with a 30-second leg stance test and it hurts, however, if you push on it right along that back part of the greater trochanter, it's not causing pain, it may not be gluteal tendinopathy. It may be something else. So hopefully something to help identify what's going on or maybe what's not going on with that patient. So let's dive into the condition of the podcast. The condition is going to be Meralgia Paresthetica. And Meralgia Paresthetica, I always learned in school, this was all about the pregnant patients, something they got all the time. And it's also called Bernhardt-Ross syndrome, as more of a historical name. I guess Meralgia Paresthetica was too hard to spell. I don't know if Bernhardt-Ross is too much easier to spell, to be honest with you. But this is a painful compressive neuropathy of the lateral femorocutaneous nerve, causes burning pain, paresthesia in the thigh. Now, the lateral femorocutaneous nerve is a pure sensory nerve, so we're not going to see any kind of weakness when you're doing your neurologic exam, but this is going to go from the higher parts of the lumbar spine, L2 and L3. So before it goes in the lumbar spine plexus, these are our upper lumbar spine nerve issues. Could still be involved with the hip flexors. Now, when the lateral femorocutaneous splits, it goes down from the lateral plexus and goes out to the outside or lateral border of the iliopsoas muscle before going into the inguinal ligament. Now, this is going to be right near the ASIS, that bump on the outside part of the front part of your hip. The most common spot of entrapment is right there, right when it dives into the thigh. And now we can see this sometimes being trapped over in the tensor fasciae lata, over in the sartorius area. Any of those spots can cause compression of the lateral femorocutaneous nerve. However, we're really looking at those outside parts of the hip. Now, here's something that I did not know. I just had it in my brain, especially coming out of school. This is a pregnant patient issue. That once the belly starts to expand due to obviously the expanding weight and size of the baby, that we have these kind of conditions. But really, this is a middle-aged adult and a middle-aged adult male problem. So something, a patient population that I maybe wouldn't have considered in the past, I will now. Interestingly enough, as with any kind of peripheral neuropathy, diabetics, especially when it comes to Meralgia Paresthetica, have a 6-fold increase of developing this condition. Now, there's a bunch of different reasons for that, but also keep in mind, diabetics don't heal like everyone else. There is not a significant side, one side or the other, as far as dominant side, right side versus left side of the hip, and it's actually bilateral in 20 to 25% of these cases. So this is one of those things that normally when we see a peripheral neuropathy, we're really looking at usually a one-sided issue. When we start to get neuropathies or radiculopathies that are on both sides at the exact same time, as far as personally, I looked at the spine. In this kind of case, we should be looking at a peripheral neuropathy. And what we're looking for is, what is that patient doing to themselves? When we have any kind of excessive compression or ischemic stretch of any kind of peripheral nerve, remember, a nerve can take about 15 to 16% stretch at one time. However, if you keep it there for a long period of time or you exceed that 15 to 16%, that's when we start to have neurologic symptoms associated with it. Now, this can be due to any number of things. Keeping in mind, my past historical thought was, pregnancy, and pregnancy is one of those, but increasing size could be obesity of a BMI greater than 30. But what we're seeing more often than not is those external factors. That's a carpentry tool belt, a police duty belt, any kind of body armor for a policeman or a soldier, or any kind of excessive tight clothing like a belt. What the research is showing is that if you have weight gain, it often precedes this condition. In fact, about 8% of new cases have gained more than 15 pounds in the recent months. So something that you want to take a look at, especially in your physical exam. Whenever we see someone that we're thinking may have Meralgia Paresthetica, how are they going to tell you what they have? I mean, think about that. When you're in practice, often you're able to guess their diagnosis before you even get your hands on them. So if you start to see a middle-aged patient, start to have a little numbness, a burning in the lateral thigh, what are the other things they could also talk about? Well, with like any other peripheral neuropathy, sleep. You know, this kind of symptom is usually worse when sleeping. Your brain has nothing else to think about. It starts to think about the damage you've done to it before, and then also any kind of compression on it from laying on it can aggravate it while sleeping. This is normally also provoked with walking. When you walk, it's intermittent extension of your hip, so that would stretch out that cutaneous nerve, and it's usually alleviated with sitting because it's going to take a little bit of tension off that nerve. How do we evaluate for lateral femorocutaneous issues? And there is one orthopedic test called a pelvic compression test. You're going to have the patient side lying, pushing down on the outside parts of the ilium and actually compressing down on that tissue. If you want to see a video of that, check it out in ChiroUp. This is a test that if you push down and hold for a couple seconds, it's going to reproduce their symptoms, just like any other orthopedic test. With any orthopedic test, really you had these fancy names that all of you and I had to remember in school, but realistically, you're just pushing on something, you're pulling on something, or making that thing work. If you think about it like that, yes, I know there's specific names that we have to remember, but when you have a specific tissue that you're looking to stress, think about pushing on it, pulling on it, or making it work. Now, as far as the actual management, when you dive into ChiroUp in the condition reference section, we're going to give you the protocol as far as how to evaluate it, but most of us really want to learn, how do we treat this thing? How do we get this thing feeling better? And there are two things that I know I use on a regular basis. Yes, I stretch the iliopsoas. I do that with these patients. However, working through that TFL, that tensor fascia lata, that's right there on the outside lateral hip, and that anterior portion is where we start to see irritation and maybe some adhesions limiting the ability and mobility of that nerve. So something you want to work out. But the most important part is a nerve release at the lateral femorocutaneous nerve. This is going to be important. When you can put stress on the nerve from the side lying position, you have the leg, that upward leg slightly bent, and you're pulling them, that leg behind them. Is that as you do that, you're stretching the nerve from below, and you can have the patient flex from above. Nerve flosses, nerve releases, these are things that what we know is that even if the nerve is not this significant problem, it's not the etiology, it's not the pain generator, it's still good to have good mobility of the nerves. The nerves have to move, they have to slide, they have to go between muscles or around bones or through fascia, and making sure, especially in the case of a peripheral neuropathy, that we do nerve releases and send patients home with nerve flosses, we can significantly alter the course of that symptom. So one thing is doing the nerve release, and once again you can find that in ChiroUp, and then marrying that to what the patient can do at home. You know, there's a lot of the conditions that we have to do strengthening, and that takes a little bit of time because we can't strengthen muscles. It requires the patient to go home and work on strengthening muscles. I tell my patients whenever I need to strengthen something, like in the case of a gluteal tendinopathy, you know, listen, Sally, here's the deal. If I give you some bicep curls, if you go do bicep curls today and tomorrow, are you going to have big bulging biceps? And Sally will look at me and be like, no, that's not possible. So they understand, most patients understand it takes time to strengthen. But in the case of this, in this kind of a case where we need to stretch things out, this should happen fairly fast. Now, nerves are slow healers, but I expect results between treatment visits and during a treatment visit. So not only am I going to do the nerve release of lateral femoral nerve, but I'm also going to send them home with the femoral nerve floss. You know, when we start to look at these things, they sound really complex and hard, but I assure you these are very simple to incorporate into your practice, and even more simple for your patients to do at home. So check out the femoral nerve floss in ChiroUp. I'm going to marry that also to a psoas stretch, which is going to be very similar to the femoral nerve floss, and then also stretching out the iliotibial band. Now, stretching out the iliotibial band, you and I both know we can't actually do that. It has a tensile strength of steel. But really what we're doing is we're stretching out the structures that attach to the iliotibial band, which is mostly that TFL, but also that gluteus medius. Remember, the anterior part of the gluteus medius has a big piece of the puzzle when it comes to iliotibial band syndrome and also gluteal tendinopathy, something that's often tight. Now, what do we do for these patients? We can do manual therapy, we can do manipulation, and I would absolutely 100% take a look at the lumbar spine. I would take a look at the sacroiliac joints because we need to make sure all the joints are moving properly. And let's face it, if you have any part of your body that's not moving well, you'll always force more range of motion somewhere else. That's why when you look at a post-surgical case or someone has a lumbar spine fusion, where do they have their neck surgery? It's the level above or adjacent level disease. And we'll see the same thing in the hip. So if we have a patient like this who doesn't really want to get into hip extension because of that pain, it reproduces their symptom, it's uncomfortable, what are they going to do? They need to get that extension somewhere. They're going to find it, just north of there in the lumbar spine. So once again, make sure joint manipulation, if indicated, is incorporated. It's going to significantly help your patients recover. But conservative management, the multimodal stuff that you and I do is the frontline treatment for Meralgia Paresthetica. Success rate is 91%. Now, just like anything else that we do, that if you are the best manipulator, the best manual therapist in the entire world, but the patient does not eliminate the cause of their peripheral neuropathy in this case, we are peeing in the wind. It's going to come back. It's like someone with, rotator cuff tendinopathy that you deliver the best adjustments and give them the best exercise and you're doing the best manual therapy, but they go home and they sleep on their shoulder every single night with their arm above their head and causing excessive compression of the supraspinatus. It's not going to get better. So in this case, do all the things that we just talked about, but most importantly, try to look for that excessive compression, that excessive stretch of lateral femoral cutaneous nerve. If you can eliminate that, that's going to be a big piece of the puzzle. One thing to keep in mind is high heels. While I don't wear those too often, but they do cause excessive anterior pelvic tilt, which is also linked to that problem. Something that I'm not especially too familiar with, but if you've seen anyone walking high heels, I'm sure you could probably get the gist. Now, just like everyone else, I don't succeed with every case. I'm sure you don't either. We would love to. What other options are there for patients with Meralgia Paresthetica and after they do your trial of care? They do 6 visits, they do 9 visits with you, and they're not getting results. You should at least consider they can do things like nerve resection, surgical decompression, or even just nerve ablation. And I'm not saying those are good options. I'm not at all. However, there are surgical options, there are medical options for those patients, for those cases of recalcitrant traces that were just not helping. So something to keep in mind is that there are other options for those patients. So, in conclusion, Meralgia Paresthetica is a patient presentation that we're going to see frequently. It is not a motor problem, it's a pure sensory problem. Not that that should lower our guard and that should lower the severity. It's still a peripheral neuropathy, but these are patients that if we can go after what's the cause, whether it's weight gain, whether it's too tight of a belt, whether it's a police belt, something causing excessive compression of that lateral femoral cutaneous nerve, we want to go ahead and eliminate that. Add in the exercise and stretches that we talked about. If you have any questions on the protocol, any questions on the research, you can always check it out in ChiroUp. That's your digital resource for these kind of conditions. Or you can always email me, Brandon@chiroup.com. If I don't know the answer, no one does. I'm just kidding. Rarely do I know the answer to too much. We have a team of people around us that can hopefully answer any questions you may have to help yourself in practice. Now, This is something that I just did a talk at Parker, which was in Las Vegas. I think it was last month, and on the dizzy patient. And to be 100%, kind of candid with the listeners right now, it was the first time I ever did that talk. Dizziness is one of the scariest things that I see in practice. However, we can't turn a blind eye and say that, oh, chiropractors don't cause strokes, so we don't need to worry about it. That's not true. Now, the fact that we don't cause strokes is true. However, patients are coming into your office with dizziness all the time. I'm sure they are. They come into my office all the time. The number 1 and number 2 symptom of people going through a stroke are headaches and neck pain. Number 3 is dizziness. So we need to be able to address that, to rule in, to rule out, to triage those patients. However, as you and I know, the number 1 cause of dizziness is BPPV, when we have an issue with the semicircular canals, and of that, the most common is going to be posterior canal BPPV. Now, people can also have cervicogenic vertigo, which is, in all honesty, a lot easier to treat, a lot faster to treat. If you check out the head fixed body turned test, it is a great way to differentiate, does someone have BPPV or cervicogenic vertigo? That's going to be beyond the scope of what we're going to talk about here. But here's what I do want to talk about, is a paper just came out about the Epley maneuver. You and I have gone over that maneuver many of times. So let's say they have an issue with the right side. What they're going to do is they're going to turn their head to the right. They're going to lean all the way back with a 45-degree turn to that same side, the right side in this case. And then you're going to wait till the dizziness goes away. You're going to rotate their head 90 degrees to the opposite side, hang out there for about 1 minute, then turn them another 90 degrees for another minute where they're laying on their side, and then come back up. Well, there is now a modified Epley maneuver, and they got better results with it. And really the main difference is this. It's the same thing as the Epley maneuver, but instead of doing the two-step, meaning as you rotate towards the unaffected side, you're going to go 90 degrees, wait a minute, 90 degrees, wait a minute. Instead, what they did is they went directly from their right side of rotation 135 degrees. So one major turn all the way to the unaffected side, and they held it for 5 minutes. Now that was the first thing, and I guess I don't see too much of a difference in that as far as a typical Epley maneuver. But the other thing I thought was interesting that I wanted to bring to your attention is the way they tested if Epley maneuver worked is 5 minutes later, they had the patient do the Dix-Hallpike maneuver, which is what the patient side of this. So once someone has BPPV on the side, on one side, you send them home with the Dix-Hallpike maneuver. But what's interesting is they did the Dix-Hallpike maneuver 5 minutes after the repositioning maneuver, and I always thought you had to wait 15 minutes. So the reason I want to bring that up to you is that personally, I would do Epley maneuver. I would sit the patient back up, and then I would go treat another patient, then come back after 15 minutes. And this was, I don't want to say it was a time suck, but the patient was in my office for a long period of time when I don't think they really had to be. So now what I'll do is I'll talk with them and then just wait 5 minutes and check again. So one, the increased hold time when you have the patient rotate their head from 1 minute down to 5 minutes. On a personal note, I usually don't even wait 1 minute. I know you probably should, but usually I wait for symptoms to subside. One thing you also want to do with those BPP patients is take into consideration that fluid, that endolymph within the semicircular canal is like oil. It's of a different viscosity than typical water. So it does take a little bit of time. So I do appreciate them going from 1 minute to 5 minutes, but just two things to take into consideration when treating those patients. I think that the last piece of the Epley maneuver is when you have a patient going down your table or coming up from your table and they have dizziness, don't discount that. This is an underserved population. Make sure you take a look at the condition reference in Chiro for BPPV, do the right assessment, do the right treatments, and people always want to see more patients. Well, this is a huge patient population. If you're able to accurately assess it and treat it, that's going to build your practice. So two things that I thought were very important. The next one, more of a practice builder, is just treat more conditions. Most people think about us as that we treat the exact condition they came in with the first time. If you help them with back pain, well, then they think that's all you treat is back pain. But if the more you can bring to their attention, you treat more conditions, the more your practice will grow. Now, this is going to be a little bit more of an opinion thing, but I always appreciate when I talk to people or I hear lectures or seminars, and I kind of can get in the brain of the presenter. And so when it comes to the podcast that I appreciate, two podcasts that really help me as a chiropractor, as far as business wise, Kevin Christie does an amazing job in the Modern Chiropractic Marketing podcast. And then clinically, Brett Winchester and Taylor Premer, two of the tip top people in our profession, really going after the secret sauce. What do we need to have in our tool belt to help ourselves as chiropractors help patients? So Gestalt Education Podcast. Those two are number one and number two in my car when I'm heading to work. What am I excited about? I think that there's a new podcast I just heard about. ChiroHealth USA, Ray Foxworth is putting one out called Chirosphere. I don't think it's out yet, but I am excited for that, mostly because I just like Ray. I like those people who you can tell are just altruistic. They have the profession's interest in mind. So that's something to maybe put on your list and to look forward to coming to hopefully Spotify and Apple podcast soon. And then finally, my guilty pleasure. So just on the way to work, I listen to work-related stuff. On the way back from work, I try to listen to something else. And I've been listening to the Huberman podcast more and more. Huberman, I think, is a neuroscientist. I think he's at Stanford. And man, if you want to dig into the nuts and bolts behind many of the questions you have as it relates to behavior, as it relates to science, as it relates to really anything that can be studied. This podcast, while it is extremely long, between 1 and 3 hours, you will not want to turn it off. So I have no affiliations with any of those podcasts, but I do believe that those are kind of build a person that I am. Finally, new stuff in ChiroUp. I wish there were more new stuff in ChiroUp, but the one thing that is going to, I believe, revolutionize the way you and I practice, it already has revolutionized the way I practice, is the EHR that's coming out. We're already using it in our office, billing, scheduling, notes. Let me tell you, it is something special. We're still on track for the summer. If you have any questions, concerns about the EHR, you can contact support at ChiroUp and we'd be happy to answer those, but it's not out yet. We want to make it perfect. It's one of those things that we're not going to rush. We're not going to put out a product that doesn't work perfectly. And most importantly, we want to be an EHR that everyone likes, which as of right now is a tough category to fit into. So once again, if you have any questions, concerns, comments, you can always email me, Brandon@chiroup.com. I want to thank you for listening to this podcast. Once again, always send in the feedback and suggestions. Like this this podcast on Meralgia Paresthetica was a suggestion by a subscriber. So we like to meet those feedbacks with real world knowledge and hopefully in a different platform. Instead of doing a blog, instead of doing a webinar, doing a podcast format, and hopefully bring out some opinions at the same time. If you haven't done so already, share this podcast or like it, and we'll talk to you next month.
Hey, thanks for listening. To access more information, visit chiroup.com. You can sign up for a 14-day trial. Use referral code podcast15 for a special discount after your trial. Offer valid on new subscriptions only.